Hi, my name is Eleanor King. I'm a core faculty member at a family medicine residency program in Michigan. My project was to implement a professional curriculum based on the tenets of positive behavior interventions and supports in our program to see if we could decrease some unprofessional or undesired behaviors. So I want to first explain what positive behavior interventions and supports are. This is abbreviated PBIS. It was a philosophy developed in the 80s in elementary, special, and alternative education. It's essentially a system of primary and secondary prevention strategies with the goal of reducing unwanted behaviors. Like we use primary prevention in medicine, primary prevention in education was targeted towards the whole student population. The secondary prevention strategies were targeted towards individuals who had already been flagged as high risk or problematic. So the way PBIS is supposed to be structured, like any type of prevention, is with a strong foundation of primary prevention strategies and then a smaller section of secondary prevention strategies once you've figured out who needs that targeted help. Our program was lopsided. We had a really strong system of secondary prevention strategies, and that was a testament to our strong clinical competency committee, or CCC, where we routinely evaluated residents who were problematic. We had a really structured system of issuing letters of concern. We had a process in place for putting residents on probation. We had routine scheduled advisor meetings for residents who were problematic. But when it came to residents that hadn't yet exhibited problematic behavior, we weren't really talking about them, we weren't really intervening, we weren't really supporting them, except for basically telling them all of our rules and regulations at orientation and then once at the beginning of the year. So we didn't have any primary prevention, like I said, except for having them sign off that they read all of our policies before they started residency. So to further delineate how this was an issue at our program, prior to my project in the academic year 18-19, almost half of our residents were on a letter of concern for professional issues. I eliminated residents who were on a letter of concern for medical knowledge or failing ITE and other issues, but professional problems specifically, 7 out of 18 residents had a letter of concern after they had had multiple episodes of unprofessional behaviors. The big subcategories for these letters were timeliness, whether it's showing up on time to clinic, coming on time for didactics, getting notes done on time, or making a bad impression on rotations. And these were almost exclusively rotations where they were not being supervised by a core faculty, and like elective rotations or rotations that were outside of our system. My thought was that they thought they could get away with it because it was so far removed from us, but we'll talk more about my thoughts on all of this. So our impression was that even though residents did value being physicians, and boy, we sure saw that during the COVID epidemic, they did not necessarily value like basic tenets of employment, where all of us have jobs and sometimes you have to do something for your job that you don't really see as valuable, but you should still do it properly. So that's where we ran into issues with showing up on time, doing things on time, and then making a good impression to preceptors who they might never work with again. We didn't have that problem when they were working with us. It was always when they were somewhere else, and they probably thought that I'm never going to work with this doctor again. I don't really like this rotation, so I'm just not going to go to it. And then I found that in our GME surveys, residents did value autonomy and independence in learning and teaching themselves things over being micromanaged. Ironically, in order to get them to correct their professional behaviors, I had to micromanage the heck out of it, but there were other areas that maybe we could have managed them less and provided a little bit more freedom. So my hypothesis was that if I could link what residents did value, a little bit of freedom, with what we valued, or I valued, professionalism and those traits I mentioned about timeliness and making a good impression, then maybe I could change the level of importance that they placed on these values. So I did this with a point system. So my intervention was essentially that every resident had the ability to earn 5 points per month. Each point had a reason for it. So you could get a point if you were on time to clinic the whole month. You could get a point if you participated in your scholarly activity and met all of those deadlines for the whole month. A point for getting all of your notes done on time that month, attending all of the lectures on time, and then making a good impression on outside rotations. Now I measured the good impression on outside rotations simply by not getting any feedback from your rotation that was, hey, so-and-so didn't show up this month, or hey, so-and-so came in wearing pajamas, or so-and-so left early every day. So residents who got all 5 of those points for that month, I would give them a professional certificate or a PC, and they could cash that in for 1 half day of self-directed learning or wellness. I said what I encourage them to use it for. You should study, you should do your scholarly activity, work on your QI project, you should attend to your own health needs, but then what they did with it was up to them. Residents who missed points could remediate or get makeup points by volunteering, and I'll talk about what those volunteering activities looked like. So a secondary thing I wanted to evaluate that's completely separate from professionalism was the statement by the ACGME that residents must be given the opportunity to attend to their own health needs, including those scheduled during working hours. Now, how a program defines that is up to them. We have a standard amount of PTO that residents can use for vacation, sick time, family sick time, whatever. But I know for myself, when I was a resident, I used it all for vacation and hope to God I never got sick. So we actually noticed that as well. Residents were planning on vacation, but then towards the end of the year, if they had all their vacations, they might not have enough days left if they got sick. So we weren't really providing any time for them to attend to their health needs because when the choice is vacation, extra day of vacation, or go see my PCP for an annual, I think most relatively healthy people are going to say, you know what, I'll take my vacation and next year I'll go see my PCP. So I had a lot of different ways to measure this whole program because I wanted, so much of it's subjective. I thought the more data I got, the better outcomes I could really focus on. So one area of measurement was pre and post survey on values. I surveyed all the residents. As your role as a doctor, how much do you value these 5 tenets that I was going to then issue the PCs for? And then I asked them those questions again at the end of the intervention. At months 1, 3, and 5, residents who did get their PC were asked to complete a reflection worksheet where I actually asked them specifics like, how do you feel about the fact that you met these tenets of professionalism? Like, were there benefits to you being on time today? Did you actually learn anything by going to lectures this month? This was here an example of one of those assignments that the residents completed. One resident said she had a more relaxed day, a little less anxiety when she came in a little bit earlier than usual, and I kind of tabulated what benefits they saw to being on time. And then I also had a pre and post survey on healthcare needs where I asked residents to remember last year, how much did you go to the dentist and how much did you go to your primary care doctor? Then after this program, I asked them again, hey, last year, how much did you go to the dentist? How much did you go to your doctor? Another area of data I got was a survey for former graduates where I asked them those same questions. How many times in your first year do you think you went to doctor and dentist? So in general, here's kind of what the program looked like. 18 of 18 residents participated initially. We're a 6, 6, and 6 program. At the end, 16 were active throughout the whole project. One resident opted out. Ironically, he is like our most professional resident, was so easy to work with during his whole residencies, and probably we are all missing him dearly right now. But he just basically wanted to keep doing his job because he liked doing his job, and he was never late, and he always got his notes done on time, and he didn't need an extra day for it. So I really respected him for that. We had another resident who was on medical leave during a chunk of the program, so he was unable to cash in or get his PC for several of the months. The program itself ran from October to February, so 5 months. Again, I did those reflection assignments at month 1, 3, and 5. The pre and post surveys were done outside of this window. So the pre-survey was done in August, September, and then the post-survey was done at the very end of the calendar year in June because I wanted them to reflect back on a year's worth of doctor and dental appointments. So just some random discoveries I found. One, when you give residents a certificate to use extra time off, they will find every loophole known to mankind to see if they can use it for their time off. Now, I anticipated this being a resident myself not that long ago. Like, what would I do with this? How would I try and manipulate the system? And so on the certificate, I had bulleted points, rules and regulations about when you can use this day, when you can't, can you stack it, can you save it? Does it roll over, etc.? And I thought of what I thought was literally everything, yet still during this time period, I had 17 requests for substitutions. Like, oh, I know you said I can't use this when I've also taken 8 days of vacation, but what if this doesn't really count as my vacation? Or what if I'm going to be on site during this time? So all of the answers were no for the most part. I made it very clear what this could and could not be used for, but in spite of that, almost all of them tried at least once. In total, I issued 70 half days for wellness or self-directed learning, and that was after residents were given the opportunity for makeup points. Like I said, 17 or about a quarter of them were only issued after someone needed to ask me a clarifying question about, can I use it for ... And then a really cool thing about this is 36 makeup activities were completed. You could look at that as, wow, residents didn't get their points for these things, but for our program, it was actually really helpful to have residents who were quick to volunteer for any type of program need because they wanted to get that extra point. So I didn't make up these volunteer activities. These are things just that happen organically at our program. So someone was sick on Christmas, and instead of like begging and pleading and searching to assign someone to cover that shift, all I did was send out a group message saying, hey, we need someone to cover. You can get some professional points for this. And within minutes, we had someone volunteer. So either our coordinator, our associate program director, our program director, or myself would just say, hey, you can get a point for this. We need someone to volunteer at a health fair on Saturday. And within minutes, we would always get a response, and we never had to formally assign someone, which historically had been like pulling teeth. So in general, unprofessional behavior fluctuated in these 5 areas throughout the program. In the first half of the program, I noticed a lot more points were lost. And then towards the end of the program, residents were more consistently meeting all 5 of those tenets and getting all of their points without needing to make things up. So as you can see in October, we had around 6 points that residents missed out on that they then had to make up. In November, more points than we had residents were lost. That was because literally every resident missed a deadline for their scholarly activity, and then some of them were still late and lost points for other things. But over the course of the program, there was a bit of a decline in the number of points that needed to be made up. Residents were getting used to, hey, I need to meet these deadlines, and if not, I'm going to have to make it up some way. So that was kind of cool to see. When I did the reflection assignments at 1, 3, and 5 months, at the beginning of the program, I required the residents to complete the reflection assignment prior to me giving them the certificate for their day off. So at 1 and 3 months, I said, hey, you're about to get a certificate, but only once you do this reflection assignment. And I got over almost 100% completion rate of that assignment. At the end of the program, I wasn't really thinking about it. I said, hey, here's your professionalism certificate. Here's your reflection assignment. Can you please send me back the reflection assignment? And when I didn't withhold, I only had a like 20-something% completion rate on those reflection assignments. And you can see that here. At 1 month, I had 14 residents completed, 15 at 3 months, but at 5 months, when I gave them their prize without having them fill out their paperwork first, only 5 of them ever filled out the paperwork. So an interesting thing I found is that when I asked the residents, hey, were there benefits to being on time? You can see that their responses were not all that varied. For the most part, the majority of residents saw benefits in the ability to have time to chart prep, and there was an increase in residents who felt that that was a valuable thing towards the end of the program. At the very beginning, about 36% of residents saw that being on time allowed them time to chart prep, and hey, that's kind of cool. Towards 3 and 5 months, it kind of plateaued at about 60%. One funny comment, which I can see, is that one resident actually said that at 1 month when they participated in this program, they actually felt more stress, and I have her actual verbiage. Essentially, she was stressed out because she was worried if she did not show up on time, she would not get her professional point. That was a one-time deal. At months 3 and 5, nobody really reported that they were more stressed, but some residents did report less stress. A lot of them said their day was a little bit more efficient. And then, a handful always say, no, there was no benefit to this. I'd rather show up 5 minutes late. So based on the pre and post surveys, This was, again, not my finest outcome, but I could see that residents didn't necessarily change how they valued things based on me creating this program for them. In some areas, it actually seemed that they valued these things less, and maybe it's from me harping on them about being on time. Maybe it's from some other confounding factors that I'll talk about at the end of the presentation. But you can see here that I defined a high value as a resident reporting on the survey that they valued the quality a lot or a great deal. Prior to them getting anything out of being on time, 72% said that, yeah, I value being on time a lot. After they got a little reward for it, 81% said that. Not a huge difference. When you look at participating in scholarly activity and attending didactics, less residents actually valued that at the end of the project than they did at the beginning. And maybe they were burnt out, maybe the first years didn't realize that they hate didactics or what have you, but there was definitely a decline. When it came to completing notes, pretty consistent, between 80 and 90% of residents felt that there was value to that regardless of the program. And then making a good impression, similar, not a huge difference. If anything, maybe a small decline in how much they valued making a good impression. The most interesting outcomes for this project were actually related to the healthcare needs during residency. When I asked residents, will you use this time to attend to your own dental or healthcare needs, 61% of them said yes. When I asked residents pre and post, and then the graduate surveys the same thing, you can see that there were some trends that were interesting. So to start off, I'd like to show that when I surveyed our former graduates, one interesting thing is that even though we're all primary care doctors, for the most part, we visit the dentist more than we see our own primary care doctor. So I guess the recommendation is that you go to the dentist twice a year and you go to your PCP once a year, but I still thought it was kind of funny. So you can see that prior to residency, these former residents were attending their dentist and their PCP at a greater rate than they were during their residency here. And then after residency was completed, which you can see at the end, these former graduates were back to nearly the same standard of visiting their PCP or their dentist as they were prior to residency. So all in all, there is a dip in attention to their own healthcare needs during the PGY 1, 2, and 3 years. So then when I asked them point blank, do you think that your program adhered to this ACGME requirement? And I used the verbiage directly from the ACGME that residents must be given the opportunity to attend to medical, mental health, and dental care appointments, including those scheduled during working hours. Do you think you had that opportunity during your residency? You can see that about 40% of former grads felt that way. Current residents before this program, around 30% of them felt that way, and there was an increase after this program was implemented. When I said, hey, why don't you use this time to go to the dentist, nearly 60%, well over the pre-intervention residents said that they felt that we adhered to this ACGME requirement. When I had residents reflect, hey, in the last year, how much did you go to the dentist? There was an improvement after this project. So when I asked them at the very beginning, last year, how much did you go to the dentist? 44% said they had never gone at all. That declined to 25% after this whole program was put in place. Saw a similar but less exciting trend with PCP visits. In the year prior, 55% said they had never gone, and 50% said they had never gone after. Because I measured this a bunch of different ways, I think it allowed for a little bit more validity to some of these subjective findings. So for example, when I asked them before they got their certificate, do you think that maybe you anticipate that you'll use this time for medical or dental needs, 61% said yes. At the end, when I said, hey, think back to last year, did you use that time to go to the dentist or the PCP? 74% had gone to the dentist at least once, and 50% had gone to their PCP at least once. So I think what residents predicted they were going to do and then what they remembered doing later was in line. Then the last way that we measured outcomes of this program was with how we needed to use secondary prevention strategies as a program. And I simply looked at letters of concern issued for professionalism problems. And again, those two subcategories were making a bad impression and timeliness. So that can all be shown with this table here. In the 2018-2019 academic year, there was no such thing as a PC. We had 3 residents on a letter of concern for timeliness, 5 for making a bad impression. The total number of residents on an LOC for professional issues was 7, and total residents on probation, we had 2. During the calendar year of this intervention, no residents were on letter of concern for timeliness. We only had 2 who had still made a bad impression, and we had a total of 2 residents on a letter of concern and only 1 resident who was on probation. So there was definitely a decline in the frequency at which our program needed to utilize secondary prevention strategies or disciplinary action. So I do think there were some confounding factors here, particularly when it came to pre and post surveys on how much residents valued tenets of professionalism, being on time, getting notes done on time, going to didactics, doing their QI projects. I think that COVID kind of threw a wrench in things. I hate to use that excuse, but in truth, I think all humans value things differently post-epidemic, particularly doctors who were working taking care of COVID patients. Residents who were called to serve essentially might no longer care as much about the little things like being on time for lectures, doing their scholarship activities. So I think that might have thrown a wrench in the pre and post surveys. And I did do the post surveys in June, so things had just started to kind of calm down a little bit here in Michigan regarding coronavirus, but they had just been in the thick of it a few months prior. There also could, of course, be some class-by-class variation. I mean, you can have a particularly naughty class that then graduates and all of a sudden you don't have any issues. And then there was a component of recall bias. I don't have their medical records. I don't know how frequently they're going to the doctor and the dentist. I'm asking them to predict what they think they might do and then try and remember it later. So that could have thrown a little bit of the data off as well. So my conclusions from this project, I learned a lot. I do think that utilizing PBIS can be beneficial in the workplace, particularly when our workplace is also a part of an educational institution. I think that it did result in a decrease in unprofessional behavior, particularly in how much we had to deal with it on the back end. I, in general, think that primary prevention decreases the need for secondary prevention, and that definitely was shown with this project. By virtue of needing to deal with letters of concern and all the negative stuff much less after we did something like this. It kind of changed the culture around being imperfect, like not being on time, having notes that are delinquent, because instead of it being a discussion about, hey, you messed up, let's meet and talk about your punishment, it was, hey, you were late, guess you're going to have to come work with me on Saturday to make up your point. And the residents didn't feel as accused, I didn't think. It was more of something fun for them to think about, and they were more willing to accept the fact that they might have to make this up in some other way. In general, it is hard to change the values of residents because, again, they are grown adults, and a lot of our values are instilled in us when we were young. So maybe me constantly enforcing professional values actually created a situation where they felt those things were even less important. I don't know. Maybe, like I said, coronavirus kind of changed their values in general as human beings. And then the last finding was that if you provide designated time for employees or residents to attend to their own healthcare needs during residency work hours, I found that they'll actually do that. So I thought that was cool, and that's something that we're going to definitely consider implementing in a more structured way this year. So that was the exciting project I did this year. If you have any questions or you want to try something similar at your program and you want some resources or troubleshooting or just questions about the presentation in general, please comment or send me an email and I'll respond as soon as I can. Thank you so much.